I still do believe that in general today, the TruSteer allows for us to be able to have a predictability of a case and to move the case along with some efficiency.
Yeah, all right. Well, I wanted to welcome my colleague and friend, Dr. Raghava Gollapudi. We're going to kind of go through the Watchman TruSteer. When to use it, how to use it, where do you use it? We'll kind of talk about all that and go over a few cases. So, I guess the one thing about the TruSteer is it increases your chance of success. Because still, Raghu, how often would you say that you can't get a Watchman
I think that that's probably the number. I think it says it's 0.5 to
in?
1%. I think that is probably the right number right
Yeah,
now.
they've improved with the sizes, right? And
Right.
now with this new sheath, it kind of really decreases the amount of failures that we have. So,
I agree. I
mhm.
agree. Some version of iterative improvements.
Yeah, so it kind of goes along with the real world, right? That's what
Right.
we're saying.
No, no, I wholeheartedly agree. I think that the older sheath, oh my gosh, the original sheath, remember Arvin? We would use that one.
Single
It was
curve, double
stiff.
curve. Yeah.
Yeah, yeah.
Mhm.
And it was so stiff and you couldn't figure out like and then the hemostatic valve would bleed like crazy.
Yeah. And
Yeah.
I feel like the other problem with the old sheath is whenever you put the device in, whatever origin, whatever you started with, it would change shape.
Right. Oh yeah, 100% right. It would really straighten out.
So this device kind of feels a little bit more stable,
It
actually.
would gain depth too, right, Arvin? Remember
Yeah,
when you'd push the old device through, the sheath would straighten out much more and you'd
maybe
you'd be
elongate,
too
right?
deep. Right,
Yeah.
right, right. Those things would be definitely different.
So this is the nice part I think about the TruSteer is the TruSteer. It actually you can move it in four ways. So you're still using your clock and counter. So I think the one thing with TruSteer is it adds the ability to go superior and inferior, which we didn't have before. You kind of really had to get a nice position with the pigtail. And then now with the flex ball and the ability to trucer, you can move superior and inferior pretty safely with this device. And I think that's kind of mostly how I use it. And still you can use the counter and clock to go anterior and posterior,
Mhm.
which is nice. So I guess this is the way I've been kind of thinking about it.
Oh yeah, yeah.
Yeah, still it's 3D, right? You're on TE, you're looking at an image in 2D. I've kind of been using my True Plans to kind of help me plan my case, but it in my brain it actually helps me think about this in a three-dimensional way because it is a 3D structure. So anterior, you counter the sheath, that'll move it. Counter the sheath, it'll move it anterior. Clock the sheath, you can move it posterior, and then superior dial towards you, inferior dial away from you. That's kind of the one added benefit I feel like of the TruSteer sheath. So, um, Raghu, you do a lot of Watchmen. So tell me how you use the TruSteer in kind of this
This.
mid deployment.
Hey, Arvin, can you go back one slide?
Oh, yeah, of course, yeah. Mhm.
So when I look at that, it's funny how you call it. Each of us call it a little different wording.
Mhm.
Like anterior, posterior, I still use those words.
Mhm.
And superior, inferior, I say, oh, I want to make this thing more anterior and superior.
Mhm.
So on that thing where it looks when the sheath doesn't look like the old single curve.
Yes.
When you want to make it look like an anterior curve, you use that dial. You really crank it towards you. When
Mhm.
you want to make it look like a single curve, you dial it away from you, and it makes it look like a flat. I call it when you have a posterior directed appendage versus an anterior directed appendage. So just how I was listening to you, I was like, oh yeah, that's how I.
Yeah.
But I don't use that word superior inferior, but that those are good words too.
I think because I look at it in 3D now with the CAT
Well, yeah,
scans that I do pre-op. So
yeah.
that
You're AI. You're like an AI king.
so I
Pretty
guess
good.
Going back to this, you do the Watchman. How do you use this kind of in the mid to kind of tuck these shoulders in, or when
Right.
you're not getting the device, as you say, when it sits cattywampus, how do you correct it? How do you use a trucier for this?
So I think so. First thing that I do is I try to figure out which am I going to be in line with the long axis of the appendage? And then how do I maneuver the device or how do I maneuver the true steer to get an angle that allows for coaxial deployment? So I think just like you're alluding to, sometimes I think the flat appendages or the appendages that are posteriorly directed with a lot of posterior depth, or so when you do a angiogram on the arteriocaudal view, and you see the appendage is only horizontal, there's no vertical depth of the appendage. There, I find the TruSteer to be very, very valuable. As you see there,
In this case right here, right?
correct, the mid panel, I
Mhm.
find it to be really, really important
Mhm.
because I'll use the pigtail to gain access to the appendage and then really dial I think it's going to be away from you
Yeah.
to bring that TruSteer into I call it flat or towards more horizontal look,
Mhm.
just like you're showing there.
Mhm.
And then really then a lot of times I'll try to I'll try to deploy the device halfway
Mhm.
and then, and people call it like when you do an anterior chicken wing, a um a hitch, what do they call the thing? A hitch?
Hinge, right? Or
Yeah,
the. Mhm.
like a hinge of the like a truck, and try to do that. And so you try to use it that way, or in this posterior directed appendage, is just try to make it look more flat. So I think the device really does help you, especially, yes, you can put the ball at a different spot, if you want to call it that,
Mhm.
within the body of the appendage, or you can maneuver the device when it's halfway deployed, and you use the body of the device to help you, and then you use the sheath as well. So different anchoring mechanisms, or two different methods of steering the Watchman to the right spot.
Yeah, so right when you kind of see those os dots, you can kind of flex this sheath, right, to kind of get
Correct.
this to sit properly. Otherwise, you have these huge shoulders and things that you don't want, and an unstable device.
Right. 100%. I think the Watchman TruSteer, especially in a big anterior chicken wing
Hmm.
or on a flat appendage or a posterior directed appendage, I think it really allows you to gain depth as well.
Hmm.
Because sometimes you can't gain depth like you're alluding to there.
Exactly, right. So yeah, I've been kind of going up front with these, so I think that's my next slide here. So for who, for what? So I use TruePlan, so I do like to kind of plan out my cases like this. And I've honestly started using TrueSteer for every case just for efficiency purposes. I really don't like taking the sheath out, going over the wire. It's just another area where I can potentially introduce bubbles or something like that. And this procedure has to be safe. I can't afford to have any complications at all for a Watchman. So here's my question for you, Regu. Do you use this in every case?
I tend to use it in every case.
Mhm.
And I think there's a couple of reasons why. I just use this for the transeptal. We just have to make sure they give me the right.
Uh, uh, TruSeer for the transeptal and the NEO. So you're saying efficiency wise, it's way quicker and easier.
Correct. Now,
Mhm.
I do get other doctors would say, well, you're spending extra $500 for the procedure.
Mhm.
But I do think that allows for efficiency. You don't have to use the old original sheath and then bring a true steer if you want to get more support. I'd say five. Honestly, I'd say probably in 30% of cases it adds value.
Mhm.
And because it adds value in 30% of the cases, and then I would just bring the true steer in to help us. So I might as well use it straight up. And I use it for the transeptal, and
Now,
I
one
use
thing
it.
is I think one area of caution is don't steer with the dilator in place. I'm not steering
Oh,
to get to the right spot. The transeptal will be kind of pretty traditional.
correct.
I'm not really using the dial to help me get a location on that.
No,
Mhm.
yeah, but you know what's funny is that some people do use an Agilus sheath. I know this is
Mhm.
completely off label to
Mhm.
do the transeptal, but people before the TruSteer came or any other, I'd I'd go proctor a lot of doctors and they'd use an Agilus sheath. I was like, oh, that's pretty cool.
Mhm.
When the transeptal was very, very hard. But I still do believe that in general today, the TruSteer allows for us to be able to have a predictability of a case and to move the case along with some efficiency.
Yeah, I've kind of switched to this. But so for those who aren't using it regularly, if someone does do pre-screening, pre-op, either with a TE or with a CT scan, who would you recommend the TruSeer for?
I think the TruSteer is really valuable for a big anterior chicken wing. When you see a big wing, I think that is real value. And a posterior directed chicken wing. if you want to call that just a windsock that's only got posterior depth. I think it adds a lot of value to be able to gain that, be able to maneuver the sheath into the appendage, and then secondarily to start to maneuver the Watchman inside the appendage as well to gain different angles. So those are the two ones where I would definitely use it. Now, in other cases, probably not as much. You don't have to use it as much. But I think on those two unique instances, it really adds value.
It's funny because we use it regularly. Now I kind of like having it because
Oh yeah.
you can really optimize the device, even in the cases that you didn't mention, like
Mhm.
something that you think is a pretty simple, straightforward case. It's just nice to have another piece of tech to kind of optimize the
Right?
device. So, you know, I feel like in the flex world, what's your toleration of leak?
Oh, zero.
Right, isn't it? It's you know this point 0.5 world in the older devices.
Mhm.
You know we were living with that all the time because you know you just wanted to be safe. But now I think you know in the world of flex, it's zero, right?
You
Yeah.
should try. I
Mhm.
suggest all the time. If you see a leak now, when the LA pressure starts to rise, the that volume of the LA is going to be bigger, the LA appendage is going to get bigger,
Mhm.
you're going to see a leak later on.
Yeah, and
And a leak may be consequent, maybe not inconsequential later on.
no, totally get it. Yeah, that's why I've been using it regularly, which
And I think I think it's the safe, it's very safe.
mhm. Yeah,
And so
that's what made it nice. It's such a great evolution since the 2016 model.
you just got to make sure. Now, the things that they didn't, they made a little iterative changes to the TruSteer
Mhm.
sheath that it comes with, as you probably, it used to come with that red wire. They used to have three wires.
Yeah.
They used to have a couple different wires, so now it doesn't come with all those wires. It just comes with the just the curlicue wire,
hmm
and that's all it comes with now, which is fine.
hmm
For me, it's fine. It's adequate for the procedure.
Now for me, since I've been using this, I've actually not been going with the sheath in addition to this.
Right?
Just been going
Same.
the 17 French, right? So
Right.
I used to do you put a big cook sheath and do my transeptal through there. I just felt that things would kind of move easier. And to be honest, I have not had that many issues with this kind of tracking through the iliacs or doing a transeptal with it. It still feels pretty smooth. So I've not been using an outer sheath.
Right. I think there are some doctors who say it's too stiff and you can't clock it as well, you can't maneuver it as well, but I disagree. I think I found it to be very, very maneuverable and it allows you to do the transeptal and not having to quote downsize it to the original Baylis or BRK, whatever else SL1 sheath you're using.
Yeah, so I've kind of ditched my sheath and just been going with the TruSteer straight up.
Correct.
Mhm. Now, 17 French, are you using one per close, two per close, figure of eight stitch at the end? How do you do this? How do you close it?
I'm all over the map, Arvin, now. I've gone from always using a pre-close, then I abandoned the pre-close completely, and then I just went to a figure of eight stitch
Mhm.
because I had a problem with the vein before where pre-close shut down the vein. So then now I've got probably a blended model, especially when we do conscious patients. Um, when there's two sheets in the ipsilateral groin. I will do two per closes now, and one per close per vein, even on the 17.
So you're doing one per close for the TruSteer sheath.
Correct.
Okay, got it. So one with that. And have you had issues with bleeding or oozing or anything?
No, it's been very well tolerated.
Okay. And do you use protamine after your cases?
It depends. I think it definitely depends. If I'm struggling a lot, I definitely will.
Mhm.
Meaning there's a lot of risk on, meaning I was maneuvering the device a lot, then I will give protamine. But other than that, I tend not to.
Got it. Okay. And then I guess for this going to this pre-close or per close using this as cost, does this offset the cost of the TruSteer if you just use a figure of eight stitch at the end?
It may. It may. I can't. Some hospitals pay up to $190 for the per close. So
I
if you
get.
use two of them, that's almost $400 right there.
You know, I guess you can kind of make it if you're trying to negotiate, you can kind of
Right?
make an argument that
And you don't need a whole new transeptal sheath.
that's true, right? So there you go from that standpoint, right?
So
So,
a little safety.
yeah. So here's a case that I did. You know, I again I used primarily ICE for this, so single operator with intracardiac echo. So I like to get a plan. So this is my true plan. We get CAT scans for my cases, and for my brain, I don't know. This kind of just helps me visualize this. So I was talking about that anterior, superior, inferior, and posterior, those four directions. This really helps me visualize it, and I'm able to get actually a nice predicted working view for this. And this has been pretty accurate. I've found. And I know historically we've been kind of doing this, 25-25 R caudal, and sometimes some of these cases are pretty different in terms of a working view. Um, but I kind of like this, especially for me because I'm using intracardiac echo. I like to use the CAT scan to clear the appendage, and as long as patients are taking their anticoagulation, I feel pretty good about using ICE from that standpoint. So here's kind of this case showing that it looks kind of funky, way different. It looks like I was just in a different lobe, but this now starts to look like what we saw on the CAT scan.
Yeah, yeah.
And this is kind of one of these scenarios where historically we'd really have to um, get get our pigtail in the right spot and then start our deployment. But now, with TruSteer, it really helps me try to optimize my angle and get coaxial with the ostium uh, to um, to deploy these watchmen. So hopefully you get less deployments, and you're not manipulating it as much, which is probably safer in the long run. So
Arvin, can I go back to that case right there real
of
quickly?
course, yeah, here you go. Mhm,
So when I look at that case, it
mhm,
looks like, and I'm not saying what happened with your transeptal, but
mhm,
when I look at that, I say, oh man, that's a hard angle to
mhm,
overcome without having to repeat your transeptal or
mhm.
to because sometimes a transeptal. I remember when I first started doing Watchmans, we'd go superior, we'd go inferior, posterior,
Every
and
time.
we'd have so many perforations. And I know that doctors don't like to talk about that, but we'd have all these perforations because you try to go posterior, you try to
Mhm,
go inferior,
mhm,
and you would have a lot of times where that quote optimal transeptal spot
mhm.
would be difficult because you go through the back
Aggressive.
wall of the,
Yeah, it's
yeah, very aggressive.
you're really pushing the limits of, oh, I kind of see it. Am I too low? Am I too posterior? You're like, yeah,
Correct.
but I
And
really
and
need.
I look at this case right there, what you just see here,
Mhm.
I look how that sheath is not turned out to be transparent. It's not optimal
Yeah.
for a coaxial deployment.
Mhm.
But I assume you're going to say the TruSteer
It
really overcame that one layer of dysfunction.
Yeah, because you can move it in four directions.
100%.
Mhm. Yeah, so here's a ice going through. It looks like Lucky again went through the septum, and
And it didn't, and Arvin, that didn't, and being a bigger sheath didn't impede you from doing the getting your ice across, huh?
no, no. Occasionally some of these septums are a little challenging, and it feels tight to manipulate the ice when they're both in side by side. So occasionally, and it also depends, I feel like, on the angle of the iliac veins.
Yeah,
Sometimes
yeah.
this bend, it just works against you, the location of that, depending on how the patient's anatomy is.
Right.
But this shows you, kind of like you mentioned, right, Raghu? My initial deployment is not satisfactory, right?
Hmm.
And then you're kind of able to manipulate. And this kind of shows you on
Oh, yeah.
intracardiac echo ICE. And again, this in my mind, it shows you the difference in my brain, the difference between 2D and 3D. I mean, this shows
Right.
you it's a nice 2D image, but it doesn't give you the full story. So my
Hmm.
brain works a little differently than yours, I know. Um, but it just shows you this Watchman is not meeting pass criteria here. So
Right.
here we were actually able to kind of manipulate the device a little bit,
Hmm.
gain some a superior angle. So I was able to move the move the TruSteer towards me, gain some height here, so move it superior, really get that puck where we want it, and the
Hmm.
device really sat nicely actually. So this is kind of we call it the high angle view in intracardiac echo. So the ice is looking from here above and is kind of coming into view, and it looks like the equivalent of like a 135 view on TE. It looks like the device is sitting nicely, so pretty happy with this result here.
That's nice.
Yeah. So here's another case. Case two. Again, I like to do my true plans. This is, looks way less complicated. And like you mentioned, Regu, this kind of looks like my angle is way way better than the first one, right?
Right.
It just looks way more coaxial
Hmm.
than the first case. We're in this optimal working view 12-22. See, that's kind of what
Oh
it
yeah.
gives me. In the traditional 25-25, this would be a little bit off axis,
Hmm.
which again my brain opinion helps me out here. So here the device is sitting in place. We're looking at this from below. This is the equivalent of that 135U on TE. And pigtail's just in the wrong spot, but again, pretty easy to manipulate this device to a more superior approach to get really coaxial and we're able to deploy the device nicely. And device is sitting well, so meets pass criteria here. So I think in the end, overall, I'm pretty satisfied with the sheet. I think for the convenience, it's definitely worth the price.
Oh
Uh,
yeah.
and it's just one case where if you have an issue, you know, changing sheaths out, flushing the sheath in the left atrium, I don't know. I don't know if it's worth the pain, the risk, all that. So
And I think the hemostatic valves works well. I
mhm,
think all the issues with prior steerable sheaths, this is a wonderful
mhm.
um, adjunct to our therapies.
Yeah, I think totally agree with you. So kudos on the evolution, and yeah, I use it every case, and I'm curious to see how failure rates continue if it can continue to drop. I don't know how much better we can get than 1%
Right?
in these cases.
No,
Of
I think these are wonderful. I think it's only added and it's very safe in the groin too.
perfect. All right. Thank you.
Thank you guys.